also is an important entity which we all come across in our day-to-day life as well. And especially being a cardiologist, we are expected not just to be aware to make the diagnosis, but also to be able to manage such kind of patients, in fact. And that's why it is very important for us to be aware what is the real problem. So we will try to have a comprehensive look about the congenital heart diseases in the other lecture, but in this lecture, we'll try to focus on the ECGs. So what are the typical features which we all can identify for these, different congenital heart diseases? For example, so atrial septal defects, we all are aware there are different types of atrial septal defects like ostium primum, ostium secundum. So if we come across this kind of ECG, what do we notice? So I have already given the diagnosis, right? Ostium secundum it is. So what are the peculiar things, characteristics, I would say? So to help you there, we have already put up some arrows as well. Please feel free to use the chat box. What do you notice? So as we already said it to help you, we can already see these are some arrows over here. Any guesses? So for example, how do we start seeing the ECG? So what are the different steps for that? So we start seeing, for example, rate. Okay, this is not a 12 lead rhythm strip or something. So rate, rhythm. mm, Then, for example, what about the abnormalities like the P wave, the QRS, the different segments, and then on an overall basis as well, you can go for the final impression. So let's start with the P waves. So what do you think? How are the P waves? Or the QRS as well? QRS, for example, so P wave looks slightly a bit broader, isn't it? If you will notice, and it does cover a small box at least. For example, especially in the lead 2, if you will notice over here. Okay, and how about the QRS? So there's some arrows as well which has been put up to make it easier for you. So QRS is definitely prolonged, yeah. And then how about the axis, especially in the V1? How is this? Is this normal? Definitely not. So when we look at over here, especially in the V1, so this is what is called as R dash pattern, isn't it? And in the inferior waves, like what is the 2, 3 AVF, as it is pointed out, it is called as there's notched R waves. So what is called as crooked sign, okay? So this is again crooked sign, which is a notched R wave in inferior leads, can again also be a ECG marker for PFO, okay, patent foramen ovale. And what happens is when there is a R dash pattern with crooked in each of the inferior leads, the specificity of the ECG diagnosis of ASD is remarkably high. So if you come across this crooked sign in the inferior leads, definitely, especially in all three, you can literally close your eyes and you can say it like this. Oh, this is definitely a ASD. Okay. So what happens in the there's already the answer. So this was about the ostium secundum, isn't it? So what about the ostium primum? So primum is the one in which you will see left axis, okay? And here the P waves will be inverted in the inferior leads, in fact, and although upright in the AVL. So if you really want to see, so what do you notice in this ECG? As I already gave you the answer. So if you'll try to look over here, isn't it? One is positive and two is negative, so it is left axis deviation, okay? And especially when we look at the P waves as well in the inferior leads 2, 3 AVF, it will be inverted in the primum and it will be upright in the AVL. Yeah. How about this ECG? This is a real life scenario ECG. So for which I already gave you an example. So what I had said it is, look for the croquetage sign in the inferior leads. Over here you see it in the 2, 3 AVF already. The lead V1 is also R-dash pattern, and so this is a typical sign which should make you alert, especially for the sinus venosus. So to summarize a little bit of the algorithm, in fact, we all are aware that ASD can be of two types further, the clockwise loop or the counterclockwise loop. So the clockwise loop again can be of two types. You can say it like this: the ostium primum and the secundum. Okay, so the one with counterclockwise loop is the one with primum ASD. In the primum ASD, LAD will be there. Okay, left axis deviation is going to be there, and notching of the S waves, especially in the inferior leads, we are going to notice. However, in the clockwise loop, as I said it, there can be further two types as well. So one can be the secundum ASD. Secundum ASD, what did I say? So it will be again normal, but croquetage sign can be present in fact. And then when you look at the P wave axis in the secundum, P wave axis will be normal, and in the other one it will be superior axis. So now coming to the VSD, ventricular septal defect. So what is so characteristic about ventricular septal defect? We all are aware that there is a physiological derangement in the ventricular wall. Okay, so it can be again of further different types. It can be, small. If it is small, it will be restrictive. Okay, it can be, so that's why it can be restrictive, moderately restrictive. Okay, so there can be different types of that. So if a patient is having a restrictive VSD, most commonly it may even have a normal ECG, but in the V1 ECG you can notice is R-dash pattern. Okay, and if it is associated with septal aneurysm, there can be increased incidence of the rhythm and conduction disturbances. Is that okay? So what is the typical thing about this? Because this is a moderately restrictive. So what is going to happen is two things you will be able to notice. The left atrium enlargement is going to happen, and also the LV volume overload. So that is also going to happen. So how do you notice for the LA enlargement? If you will look carefully over here, so for example, what about the other features? What other features you will notice? So for example, in this ECG, what do we notice? So over here, definitely axis is pretty normal, right? And then we notice is the left atrial enlargement. So the first deflection of the ECG is always for the right atrial, and the second deflection is for the left atrium. And especially if there's negative component is prominent, it again will point towards the left atrial enlargement. Okay, so how do you comment about the volume overload, for example for the LV? You notice there's tall R wave and tall peaked T wave in the inferior leads. So here you notice those two, three AVF, right? So in these three, what do you notice? As I said, it is there, isn't it? This R wave is pretty tall, pretty tall. So this is why it is going to be a volume overload. Moreover, other than that, you also notice there's prominent Q waves and tall R waves with tall peak T waves in the V5, V6. Isn't it? It is pretty tall. So that's why it shows further the volume overload is there. There's some Q waves as well, isn't it? So this is not due to myocardial infarction, but this is due to volume overload. Yeah? Restrictive, we are aware, not much of changes will happen. Moderately restrictive, we are aware. Then, how about the non restrictive ECG? What will happen in the non restrictive ECG? In the non restrictive ECG, as we can see it over here, there's peaked P waves, isn't it? From V1 to V4, tall and peaked. And there is also signs of the right ventricular hypertrophy. And how do you say that? Because in the V1 to V4, you notice the prominent R waves. Yeah? Prominent R wave in V1 to V4, and V5, V6, you see prominent S wave, in fact. And also, there's also left ventricular hypertrophy. Left ventricular hypertrophy, that there are different criteria if you'll try to just see the AVL. Otherwise, also the sum of the R wave in V5, V6 and the sum of the S wave in the V1 and V2 as well. There are different criteria for that. We have already covered those in the earlier sessions. So how do you classify the ventricular septal defect? To make it a little bit easier, as I had already said it, there are two things which can happen. One is only the left ventricular hypertrophy will happen, otherwise both sides will get hypertrophied. If both sides are getting hypertrophied, it simply means only one thing. It means it's a non-restrictive type. Otherwise, if it will be left ventricular hypertrophy only, so it can, yeah, 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 yeah. Is it better now, or is it still echoing? Just a second. Let me try to use another microphone. Just a sec. Hello. Now is it better? Oh, wonderful. Maybe it was the headphone problem. Okay, good. So yeah, thank you. So as I was talking about the different types, so we should be able to understand the mechanism as well, what is happening. So as we are now already aware about the VSD algorithm, so the other thing what we all have to keep on thinking, as I had said it, for example, the non-restrictive VSD, so there will be a large left to right shunt, and that is the reason in the ECG as well, which I had shown it, we do expect a right axis deviation There will be a right atrial or combined right and left atrial enlargement. Similarly, we can notice what is called as a biventricular hypertrophy. I showed you an example, isn't it? So that is what is called as the cat's walk-tail pattern. Okay, cat's walk-tail pattern. So crocodile's sign was for the ASD. The cat's walk-tail pattern is for the VSD. Okay, but if it is biventricular hypertrophy, right? Similarly, if you will be able to notice, as I had said it in the non-restrictive VSD, simple, think it like that. Why is it non-restrictive? If there is no restriction because of the by both the sides the flow is happening. So that's why there will be biventricular hypertrophy. The LVH will also happen, right ventricular hypertrophy will also happen. That is why, as I already showed it to you, there will be tall R waves in the V1, large diphasic RS complex in the mid precordial leads, and deep Q waves with tall R waves and deep T waves in V5 to V6. Okay, so that's what I was trying to tell, isn't it? So what do we notice in this one? So there are other ways to define the perimembrane VSD as well. So for example, it can be inlet VSD, multiple VSD, or perimembranous VSD as well. So on the basis of if for the perimembranous VSD, if because they can be associated with septal aneurysm, so one can expect a left axis deviation for that. Similarly, inlet VSD can be there, which can have a counterclockwise loop. That's why we notice a left axis deviation but with prolonged RI interval. Similarly, for the multiple VSD, we notice clockwise loop with left axis deviation, isn't it? So how about this Eisenmenger syndrome? We all remember. What is Eisenmenger syndrome? Okay, we'll speak about it sometimes later and all. But uh, so common things, at least what we expect is, see, ASD, VSD, and PDA, we all are aware that they are different entities. However, their presentation can be a bit similar. So what is called as P pulmonale. So P pulmonale will refer to the right atrial enlargement. So the right atrial enlargement can be expected at least in quite a lot of cases of the ASD, but less unlikely in the VSD because everything in the ASD is happening on the upper chambers. So you can expect it more often. Okay. And the VSD, of course, goes to the lower chamber, PDA even further. So that's why the RVH, for example, the RVH will happen most commonly in the ESD, but only in the less oftenly in the VSD, and maybe similar or even a little bit less in the PDA as well. Okay. If you will recall, what are the conditions in which we can expect Q wave in V5 and V6? Can anyone recall for that? So Q waves we expect in the V5 and V6, especially in the volume overload. So what are the conditions in which volume overload we can expect in the PDA and occasionally, of course, in the VSD as well, which we already gave you some of the examples. So one of the important things we all are concerned, how about the severity of the shunt? So for example, it will depend uh, how is the shunting is happening. For example, if so it can be again mild, moderate, or severe. So if you look at the pulmonary flow to the systemic flow ratio, if there is more of pulmonary flow or is it more of systemic flow, and on the basis of that you can again uh, with this ratio you can comment on the size of the shunt as well. Okay, if the ratio is less than 1.4 it will be mild, but if it is more than 2 it will be severe. Similarly, if you notice there's a right atrial enlargement, so you can already notice, so most of the things are going in the right side rather than going to the left side. So of course, if right atrial enlargement, do you notice, chances will be it to be more towards the worst side, so it is moderate or severe. Similarly, for the RV volume overload, Again, it can be moderate or it can be severe, isn't it? And then similarly for the crooked sign will be, again, as I had said, it is what happens is this will be more of the severe sign. And isn't it the reason as well I had said it? What do we notice during the crooked sign will be the fragmented QRS, especially in the 2-3 AVF. And we can also sometimes notice the evidence of the PAH, pulmonary arterial hypertension. Yeah. So how do you identify the situs? So there are different ways. So we all are aware of what is called as the situs solitus. Situs solitus means everything is normal. Situs inversus means it is inverted. Okay? So inverted means what is going to happen is in the one AVL, P wave will be opposite. Opposite means inverted of course. But it will be going to be upright in the AVR. Yeah? Because it's all about the where is the atrial, where is the atria. So on the basis of the P wave direction, because then you can comment about it, isn't it? So what happens in the situs solitus with dextrocardia? So this is the ECG in front of you. What do you notice? Even now there is echo. Yeah, and even now there is echo. Um, when I am hearing you, it's loud and clear for me. Okay.
But we can hear a small echo in your voice, sir.
Now is it better or is it still same?
It's somewhat better, sir.
Okay, that's a bit strange. Okay, at least good that now it is not there.
And now it's loud and clear, sir.
Okay, good, good, good.
Please
Okay,
continue.
okay, wonderful. So what do we notice in this ECG? So if we look carefully, as I had said it, one of the important things to look is in one in AVL, okay, and AVR. So if you look carefully, there is upright P waves in the lead 1 in AVL, while in the AVR it is inverted, okay. Similarly, we notice that counterclockwise depolarization in the limb leads shows Q waves in leads 1 and AVL, isn't it? Similarly, if we look further in the V1, V2, what do we notice? The R waves are very prominent. Yeah? Similarly, the RS complexes in the right precordial leads are pretty prominent as well. How do we see? Is it a D loop or is it a L loop? L loop is for levo, D for dextro. If we notice Q waves in the left precordial leads, this is what is called as the D loop. Yeah? If it will be L loop, there will be Q waves in the right precordial leads and, of course, absent in the left sided. So, as simple as that, if there are Q waves in the opposite leads, so for example, as I said it for the D loop, it will be Q waves in the left precordial leads, and for L loop, there will be Q waves in the right precordial leads. Okay? So that's what it is. Situs solitus. Let's give you a twist. How about situs inversus dextrocardia? What do we notice here? What is happening? So if we look carefully, over here, this is like the mirror image dextrocardia. So the P waves are inverted in one AVR and upright in the AVR. And the QRS complexes and the T waves are negative in the one AVL and positive in the AVR, if we look carefully, isn't it? Similarly, the QRS complexes are all tall in the right precordial leads and diminishing progressively towards the V6. Finally, in fact, we also notice the septal Q waves in the right lateral leads rather than left lateral leads. I'll try to give you an overall summary as well because it can be quite a lot confusing for all of us to be able to keep it in mind. Okay, Situs solitus, inversus, okay, in both the types. So if we keep a look on the one, AVF and V1, it'll make us, it will make it really, really easy for us to be able to differentiate for all of them. Okay. What about the visceral heterotaxy? So, see, I'm such a nice person, isn't it? I always give you the diagnosis as well. But you have to tell me, how do you diagnose this left isomerism? So what happens in the left isomerism is the sinus node is absent or actually hypoplastic. So the atrial pacemaker is ectopic. Therefore, the P axis is going to be abnormal, isn't it? So what do we can notice? We can notice wandering atrial pacemaker, ectopic atrial bradycardia, or even sometimes complete AV block. Yeah. Similarly, what about the right isomerism? What do we notice? So there is going to be bilateral sinus node. And actually, there can be like two AV nodes, okay? So that's why the P wave axis is actually as normal, I would say. And the right sinus node is the dominant pacemaker. So that's why alternating QRS patterns can be seen, which could be due to the antegrade conduction through either one of the two AV nodes. So a lot of times we can notice PSVT, paroxysmal supraventricular tachycardia, due to re-entry between the paired AV nodes. So this is how you differentiate. Okay. So for example, you can again classify them into the clockwise loop, counterclockwise loop. In the clockwise loop, you try to see for the axis. Is it normal? If it will be normal, then you can think of most of the times tough but pink. But if it is right axis, there will be a lot of differential diagnosis. Similarly, you will have to consider. However, if it is going to be left axis, it will be an adult tough. Okay, and if it is going to be counterclockwise loop, again you try to see for the axis of the ECG. Is it a left axis, right axis, or normal axis? If it is right axis, your diagnosis is limited to DURV, double outright right ventricle, VSD, or pulmonary stenosis. Otherwise, if it is normal axis, it can be like type 2C. Yeah? So what happens in the ECHDs with the clockwise loop or the counterclockwise loop? If it is counterclockwise loop, if the axis is going to be left-sided, most commonly it can be is inlet VSD or AV canal defects. Similarly, if you notice there is a clockwise loop and there is going to be normal axis, then most likely it can be a small VSD or mild PS or coarctation of aorta as well. Similarly, for the left axis, it can be multiple muscular VSD, okay, with LTGA plus VSD, yeah. Okay, time to stimulate your brain. What do you notice in this ECG? So what do you notice in this ECG? So the history is already written for your reference as well. 26-year-old asymptomatic, but once you try to auscultate, you noticed you notice this. There's a heart murmur. So in the ECG, is it a? How about the rate and rhythm? Is it a tachycardia? Is it a sinus or not sinus? So we notice it is a sinus rhythm ECG, and heart rate is slightly in 90s. Yeah, agreed. How about the axis? It is right axis deviation. Then looking at the P wave, it is tall P waves. Yeah, so this is right atrial enlargement. Good. How about the V1, V2? If we notice, right ventricular hypertrophy, right. Similarly, if we look in the V1, R-dash pattern, and in the inferior lead, something interesting, Crooked sign, as I said it. So what it is? Crooked sign with right axis deviation. Ostium secundum. Okay, let's move on to the next ECG. 40-year-old male with heart murmur. Is it sinus rhythm or not? It is sinus rhythm. Then axis is right axis. Similarly, P pulmonale is there, so right atrial enlargement. And looking at the V1, right ventricular hypertrophy. So what does it show? ASD with Eisenmengers. Another patient, ECG in front of you. Come on, rapid fire. Quick, quick, quick. Sinus rhythm is there. Axis is left axis. What else do we notice? Right atrial enlargement is there. How about the PR intervals? You can call it like a trifascicular because there is a right bundle branch block with left axis deviation, and PR is also slightly prolonged actually. Yeah? And there is right ventricular hypertrophy as well. And you do notice there's a R-dash pattern in the V1. So what does it point out to? ASD, but ostium primum. How about this young guy? What do you notice in this one? Okay. So what do you think? What do you think? Come on, have a look on the ECG at the steps which I had said it already. So what do we notice? It's a young guy. I already give you the hint. It is, of course, congenital heart disease. Isn't it? It is sinus tachycardia. We can see the P waves in front of all of those cures. Axis wise, right axis deviation. How are these P waves? Because the patient is in tachycardia, So it can be a little bit difficult to say, but right atrial enlargement is there. Yeah. Then, by looking at the V1, there is right ventricular hypertrophy, right? Then we look at the V5, V6. What does it further say? LV volume overload. Okay, so what is that sign? Katz-Wachtel phenomenon, which is characteristic for the VSD. So biventricular hypertrophy is there. So what does it mean? Biventricular hypertrophy with right atrial enlargement. There is large left to right shunt with high pulmonary vascular resistance. Yeah. What is happening over here? So is it sinus rhythm or is it something else? So this is sinus rhythm, yeah? How about the axis? Again, a right axis deviation. By looking at the V1, V2, any hypertrophy, you would say this is right ventricular hypertrophy, right? And as we already noticed, there is monophasic R wave in the V1 and S wave, especially if we look in the V6, there is reduced amplitude of S in the V6. So what does it mean? This is VSD with Eisenmenger, right? Let's make it a little bit simple twist. This is a ECG. We have already given you a big hint. You can look something in the V1, the V6, deep S wave in V1, a tall R wave in V6. So it is left ventricular hypertrophy criteria. Rest, axis wise, it seems fine. Rest all is good. So what should you think of? Coarctation of aorta. How about this 45-year-old lady with the exertional breathlessness and a ejection murmur? I'll give you a hint. I am a nice person, isn't it? So these two areas you should try to focus upon. People say to me that I'm a super nice person. So I'll try to show you my super niceness. How? I'll give you one more ECG. Another 25-year-old but cyanotic. I'll show you my extra generosity. How? You can comment about the pulmonary blood flow. What do you say? So if you look carefully at the ECG rhythm-wise, the patient is definitely in sinus rhythm, isn't it? Axis-wise is right axis deviation. By looking at the V1 itself, we can say it is right ventricular hypertrophy. However, we notice that, for example, from V1 to V2, the R, which was more prominent in V1, becomes less prominent compared to the S wave. So transition tends to happen around V2. Similarly, the adequate amplitude of R and T waves in V5, V6 leads. Yeah, that's what. So, what does it mean? There is moderate pulmonary blood flow, which is characteristic of tetralogy of Fallot. So, what is happening over here? 1-year-old cyanotic boy comes to your clinic with this ECG. Since I'm super nice, I'll give you one more ECG now, and some hint as well for you. What is happening? So, what do we notice? We notice, see, even there's something written over here as well. You can take some inspiration from that. There is again sinus rhythm with right axis deviation. P wave seems to be pretty normal, right? And then while looking at the V1, V2, it seems like a right ventricular hypertrophy, yeah? But in V5, V6, is there any Q waves anywhere? Yes. So what it is? PDA with Eisenmingerization. What about this neonate? Neonate with cyanosis and dyspnea. What is happening over here? There is sinus rhythm with right axis deviation, right atrial enlargement with right ventricular hypertrophy, and Q wave is present in one in AVL. So what do we notice is DURV with subaortic VSD and pulmonary stenosis. Another neonate with cyanosis. The ECG is in front of you. This is again sinus rhythm, right? And axis is left axis deviation. And looking at the P waves, right atrial enlargement, any comments on the chamber hypertrophy, left ventricular hypertrophy, right? And the patient is cynosed as we are already aware, so it is tricuspid atresia. How about this ECG? Are the changes similar to the one which we already spoke about? Here, definitely, because right atrial enlargement is quite a lot pronounced, I would say. Quite a lot pronounced, especially if you notice. So, this is the same case of tricuspid atresia, but in another patient. A grown up young boy with palpitation. Sinus rhythm, yes, but how's the P waves? They are very tall but widened as well. So, what is called as Himalayan P waves. And there is multiphasic, low amplitude, bizarre QRS complexes with multiple deflections. Yes, and you do notice prominent Q waves in the right precordial leads, which is again characteristic of Epstein's anomaly. What do you notice over here? How are the P waves? And where are the Q waves? Do you notice any Q waves? So they are like the similar case like earlier one, isn't it? So that was again a Epstein's anomaly. What about this guy? 35-year-old female with giddiness. Come on, use the chat box. You know the diagnosis very well. There is left axis deviation. PI interval definitely seems like slightly on the higher side, yeah. And in V1 to V6, there is Q waves as well, but it's not there in the V5 V6. Yes? And the T waves are very prominent. So what is the diagnosis which I had said it earlier itself? CCTGA. So sorry about the poor quality of this ECG, but what do you notice over here? Look at the rhythm strip. It will give you some interesting insights. This is a old, young patient itself, pretty young. You notice like P waves and QRS waves are not correlated. But how's the QRS? It is narrow. In the left precordial waves, there are tall R waves. Newborn with such ECG. So, complete heart block in congenital. Congenital complete heart block. So the key thing which we all should remember is that yes, one in like 2,500 to 20,000 live births, yes, it can happen, especially if there is a maternal history of maternal SLE, otherwise NTSSA or NTSSB autoantibodies, and it is significantly associated with the congenital heart defects. In fact, 90% of the newborns with isolated congenital heart blocks can have long survival. Okay, this is a patient which is asymptomatic. So what do we start noticing? I want to give you time at least of 2 minutes. Think about it and tell me. See, I'm not interested in the diagnosis. It's okay. It doesn't matter if you don't tell me the diagnosis, but at least tell me the findings. What do you notice? This was a young female patient who had just come for, for her routine checkup and all. She didn't have any problems. And you did the ECG and you came across this. Is this ECG fine or anything would you like to say? So what do we notice? In this we can see this is the again in patient is in sinus rhythm. The axis is right axis deviation. However, in one in AVL, if you notice there is a positive and negative QRS. It is negative QRS. And AVR, it is positive. So a lot of times someone may think that there may be lead reversal, but there is no lead reversal. Okay? In fact, if we try to look at the left precordial leads, there is progressive reduction of the RS amplitude. So this is an example of levocardia or dextrocardia. So definitely dextrocardia. Okay? That's why I was telling one can even think of lead reversal. But with situs inversus. Okay? So I hope you were able to understand. So as I said it, see, no one always expects you to be able to make the correct diagnosis because there are a lot of other tools which is available for making the correct diagnosis. What at least is expected is to be able to approach the ECG in a good way. So that is what is the most important thing. Rest everything else can be done. Okay. So I thank you all for your kind attention.